Welcome everyone to our long-acting injectable buprenorphine webinar today. I'm Michelle Campbell. I'm the Clinical Director at NADA, and I'm joining you today from Wiradjuri land. I'd like to pay my respects to the traditional custodians of the land I'm standing on today, and to elders past, present and emerging, and to any Aboriginal people joining us online today and across Australia. Today, all participants joining the webinar will be in listen and view mode only. After the presentation, there'll be a Q&A. You can put questions into the Q&A function at any time during our time here, and just type it in the Q&A box at the bottom of the screen. So the webinar is being recorded today and it will be available on the NADA website at a later date. So firstly, I'd just like to do a brief introduction. Acknowledging their role in shaping policy, education and services. We acknowledge through their guidance and diverse experience and peer support, lives are saved, health outcomes are realised. And we acknowledge the participation takes courage, gives a voice and reduces stigma and discrimination in our community. I'll just give you a brief introduction and then I'll introduce our speakers today. So, long-acting injectable buprenorphine has been a significant development in the opioid dependence treatment. It may not suit everybody. Some people may prefer the sublingual buprenorphine or methadone. And it's also important that people are given accurate information around their options of treatment so they can have informed choice and choose something that suits their needs. There are a range of services across the NGO sector who provide options for people on opioid treatment, and two of these will be discussed today. So we have Carolyn Stubley and Fran Pidcock, who will be talking to us shortly. There's no one size fits all, and the NGO sector has a range of services to suit different needs, right from early intervention and prevention right through to abstinence-based services. Some of the resources that we'll be talking to today are here, and we'll also put the links to these in the chat so you can get those. There's also the newer guideline, which we'll be talking about later as well. Okay, I'll stop sharing now. So I'd like to introduce our speakers for today. So firstly, we have Professor Nick Lintzeris, who's worked in the field of addiction medicine for more than 30 years in Australia and the UK as a clinician, researcher and as a contributor to health services policy. Nick was the lead author on the long-acting injectable guidelines and was until recently the Director of Drug and Alcohol Services at South Eastern Sydney Local Health District. After Nick, we'll have Carolyn Stubley, who's a registered nurse with extensive experience in drug and alcohol and mental health fields and has worked in opioid substitution treatment for 23 years. Carolyn set up the dispensing services at Who's in Rozelle and coordinated harm reduction strategies across 7 Who's programs. Carol's expertise lies in OST, Hep C prevention and treatment, therapeutic community programs and harm reduction. And we have Fran Pidcock from the Buttery, Fran has a background in nursing and has specialised in the areas of mental health and alcohol and other drug treatment for over 20 years. She's currently the clinical operations manager with the Buttery. She enjoys harnessing her position to advocate for the needs of the community and the sector. Both Carolyn and Fran are on the NADA practice leadership group as well. So I thank all of our presenters for being here today. And we'll start with Nick. So Nick, if you can give us an overview of buprenorphine.
Thank you, Michelle. I'm just going to share my screen. So I've got just a couple of slides because I think it's easier to talk about things. Let me go to the beginning though. Oops, wrong one. Stop share that one. Sorry, folks. Helps if I share the right. There we are. Okay. So you can see that.
Yes, yep.
So I'm going to quickly walk through then just a few quick slides to give a bit of orientation to what this new treatment is. Also, just to highlight, you're going to see lots of different ways of referring to this. Sometimes it's called long-acting injectable buprenorphine. Some people call it extended release injectable buprenorphine. Some people call it depot buprenorphine. So there's different terminologies getting used. The most recent consensus in New South Wales is that we're using the long-acting injectable buprenorphine terminology, LAIB. But you may see other things like LADB, XRDB. So there's a number of different ways to refer to it. Just to position where this medication fits in the broader treatment of people with opiate dependence. So we think about opiate dependence is not a rare condition, so it affects up to 1% of the adult population. And you can see when people come to treatment, people with true dependent use generally need to go through a withdrawal episode if they then want to continue in some form of post-withdrawal treatment like counselling or resi rehab. And we can do detoxes in multiple ways. You know, generally now, increasingly, most are now done as outpatients, and most are now done using doses of buprenorphine as the medication, actually. But you can see then, you know, for the opiate agonist treatments, in Australia, we've got methadone and buprenorphine. Most treatment is long-term because opioid dependence is a long-term condition. And for most patients, when they're looking at stopping their opiate agonist treatment, they may think about, you know, coming off their methadone or bub and from there going into a resi rehab. Some people might want to use the resi rehab as a way of coming off, for example, at the WHO's program. And so you can see that tends to be sort of the majority of people in treatment on any given day with opiate dependence in Australia are in opiate agonist treatment. There's more people in opiate agonist treatment on any given day in Australia than all other forms of drug and alcohol treatment combined. So this is by far the biggest slice of the treatment sector in Australia. When we look at the uptake of the medications over time, this is data looking at what's happened comparing sublingual to the long-acting depot. You can see what's happened with the numbers of patients on sublingual. If anything, slightly, that's the red line on top, slightly diminishing in numbers. So across Australia now, there's around just under 15,000 on sublingual buprenorphine. And you can see that the depot buprenorphine has now become the most commonly used form of buprenorphine in Australia for treating opiate dependence. So what we've seen in the last 5-10 years is a reduction in the numbers of patients on methadone. Methadone used to be around 60% of the Australian treatment system. It is now just under 50%. So buprenorphine is just over 50% of all treatment, and the depot is over 50% of all buprenorphine. So the depot is probably around 30% of all treatment, opiate dependence treatment. So this is, and continues to increase. That's the thing. It's not like it's plateaued. So there's a good chance that over the next decade or so, we see that the depot buprenorphine probably consolidates at having around 40% to 50% of all opioid dependence treatment in Australia. The vast majority of it is Buvidal treatment. Buvidal accounts for around 90% of long-acting depot across Australia. The other medication we have is Sublocade. And you can see the differences, the kinds of doses that are getting used there. I'll look into each of those doses. The vast majority, though, are monthly Buvidal doses, the vast majority. So there's not a lot of weekly Buvidal being used. It's just used as a transition medication. So most patients are getting their Buvidal or their Sublocade once a month. So what is Buvidal? Buvidal comes as either a weekly or monthly dose options. In the weekly, you've got a range of options from 8, 16, 24, or 32. And with the monthly, you've also got 4 dose options of 64, 96, 128, and 60. These come as pre-filled syringes, so they're actually pretty easy for nurses, pharmacists, and doctors to handle and to administer. They're pre-filled with their own needles, so they're pretty straightforward in terms of actually handling the medication. The Buvidal you store at room temperature, and you can administer it in lots of different parts of the body: buttocks, abdomen, arms, thighs. A lot of information here, but the key thing really is the table on the right highlights how it's really easy to transition between daily sublingual buprenorphine, Buvidal weekly, and Buvidal monthly. Those dose conversions work pretty accurately. They tend to work, only in 9 out of 10 cases, these sort of dose equivalencies work without having to adjust the dose. So pretty easy to moderate treatment. You can transfer from low-dose methadone, less than 30 milligrams, directly to Buvidal weekly. Otherwise, we generally suggest that if you want to transfer from methadone to a depot, and you're above 30 milligrams, then looking at ways of transferring to sublingual first and then swapping over to the depot. Just also to highlight that when we say Buvidal weekly, we don't necessarily mean every 7 days. There's a bit of flexibility there because, things happen. There's public holidays. People sometimes are late for dosing, whatever. So you can see with the weekly dose, we say it's a dose you can administer between 5 and 9 days. Similarly, the monthly dose, we say is a dose you can administer between 3 and 5 weeks. It doesn't have to be bang on the 4 weeks. There's a lot of flexibility with the depots. It's not as though this medication works for 28 days and then stops working. There's as we'll see later, for most patients, once they've been in treatment for a while, it actually takes around 5 to 6 weeks after your last Buvidal dose, monthly dose, before the patient starts to sort of experience withdrawal. So that's Buvidal. Sublocade is the other medication, not as commonly used in New South Wales, but still there's nothing wrong with it. It comes only in a monthly dose, and the doses are only 100 or 300 milligrams. A little bit fiddlier to use because this medication needs to be kept in cold storage and that's a bit of a problem. Cold storage for a Schedule 8 medication, it's a bit of a hassle. You've got to have a fridge and a safe, or a safe in a fridge. So it's kind of not easy. It's not easy for a lot of services to store Sublocade. At least, though, you can have it out of the fridge for 28 days and still use it. Also, with Sublocade at this point in time, technically, it's only to be administered into the abdomen. And the Sublocade does cause a little bit of a lump, bit more of a lump than the Buvidal. Most patients can feel it as a sort of a pea-sized kind of lump for a week or so after administration. So, what are the potential advantages and the potential disadvantages? Why has this become the most common form of buprenorphine treatment within a matter of 5 years since registration? Largely, it is patient-driven. It is largely patients are choosing the depots because they're just so much more convenient at so many levels, going once a month for a dose as opposed to having to go in daily or several times a week. So it's the convenience factor. There's also, with convenience of not having to go in as often, there's also patient costs for travel as well. A lot of patients describe much less stigma. It's not as though you have to hide your medications or that, from your colleagues or from family members and things like that. And not having to come up with excuses why you have to, leave work early to, go to the chemist and things like that. There's less risk of non-medical use, i.e. the idea of patients selling their medication to others. And that's because the patients never get to handle the depots. So they're never dispensed to a patient. The doctor or the nurse practitioner writes the script, the pharmacist dispenses it, and then either the pharmacist, nurse, or a doctor is the person administering the medication. The patients or carers never get to handle the meds. There's no takeaway doses with the depots. Now that makes it much easier to do a lot of treatment. Like with takeaway doses, when you're a prescriber and you're authorizing takeaway doses, you have to do those risk assessments. Like, is the patient going to be safe? Are their family going to be safe? Are there young kids at home who, and the patient isn't storing the methadone safely and things like that? So you don't really have to worry about those kinds of things with the depot because you're not giving takeaways, which means we don't have to do things like the regular urine tests and things like that. Along with that, there's much less risk for conflict with patients, things like patients wanting more takeaways, but as a clinician, you don't really feel comfortable in giving them more takeaways, or patients turning up intoxicated and having to say to them, sorry, we can't dose you today, or patients turning up late for dosing, then getting upset because the pharmacy or the clinic shut. So all that kind of stuff that happens on a day-to-day basis with opiate treatment, that a lot of that stuff is just hugely diminished. Clinical trials have now shown that we get better treatment retention with the depot than we do with methadone or sublingual, and much better patient experience and satisfaction. So the patients report that this is more convenient and more effective treatment. The other work that we've been doing recently, I'll show you a slide in a moment, work that we've done with WHO's, so with Caroline's team, it also looks as though this is a much milder withdrawal syndrome when people stop the depot than what we've seen when people stop sublingual buprenorphine or methadone. Some of the potential disadvantages we've already spoken about some of the side effects and autonomy over, some patients lose autonomy over their use of medication. And then I just want to finish up, as I said, I think this is important for people working in resi rehab sectors to understand what happens when patients stop their Buvidal. Now, this is work that we, a group of researchers and clinicians from South East Sydney Local Health District, so from the Langton Centre, working with WHO's, OSTAR in Rozelle. What we did is we looked at, we admitted 24 patients who were on Buvidal doses, and basically monitored them for up to 16 weeks after the patient got their last injection of Buvidal monthly, 64 milligrams. And basically what you can see there in the graphs on the right, it highlights sort of what happened to the withdrawal severity. And basically, we hardly saw any withdrawal. So these are really mild withdrawal scores. Really mild. You can see the COWS, which is the scale we most commonly use. And that's a combination of subjective and objective opiate withdrawal. So, both symptoms and things that patients feel and also things that nurses see, so things like goosebumps and things like that. And you can see there that at its peak, the peak was around week 7, 8 after the last injection. But even at its most peak, it still did not even really reach mild withdrawal severity. So what we've got here is a medication that when you stop it is associated with very minimal withdrawal discomfort that typically is happening, as we said, around week 6 to 8 after the last dose of Buvidal. The one thing I really want to highlight, though, is that just because we've got mild withdrawal that needed very little in the way of support or medication, it doesn't mean that our patients are not at risk of relapse when they stop their medication. Opiate dependence is a chronic condition and people relapse. And they relapse not just because of the severity of their withdrawal. They relapse because life happens, and I'm sure many of you understand. So just really want to highlight, and you can see there what happened to the cravings. Even though the withdrawal was over and done with and never really severe, the cravings did continue to increase with time. And so I think it's really, really important for us to understand that even though patients may have, done really well in long-term opiate treatment, when they stop, and now we've got an easy way to stop with the depot, patients still need ongoing support. And I think that's, for us, is a really important take-home message. And I think most of the people here would understand that, opiate dependence, or the treatment really of any addiction, is never just about medication. You've also got to talk to the client as well. Okie doke. I'm going to stop sharing and throw it over back to everyone else. Thanks for that.
Thanks, Nick. That was great. And just a reminder too that you can put your questions in the Q&A at any time. We do have one question there, but we'll get to that in a little bit. So we'll go straight on to Carolyn to tell us a bit more about what WHOS are doing in this space.
Okay, thanks, Michelle, and thanks for inviting me to the webinar. For those who don't know, WHOS, or We Help Ourselves, have been working with people on opioid treatment since 1999. So we've got a long history, starting with our WHOS O-Star program, which is where people come in to reduce off opioid treatment whilst they're doing the therapeutic community program. And in 2009, we started up the WHOS RTOD program, which is for people wanting to remain on their treatment. So historically, we were working with people on methadone and buprenorphine, and that entailed any dosage of either. We don't have any restriction in terms of what we accept in terms of opioid treatment. We knew that the depot was coming and had to look at how we were going to manage that. And I should say, with WHOS, we have up to 50 people at any one time on opioid dependence treatment. So that also meant we have a license to dispense on site at WHOS. We have our own little dispensing clinic because it's a lot to send 50 people out to pick up medications in the community. And we've been very lucky to have those, specific programs. Because of the numbers, it's easier for us to manage all the scripting. We have our own prescribers. And it was interesting when Depot came on board because one of the prescribers we used hadn't taken up the Depot prescription. So we actually then relied on some Sydney Local Health District doctors who came to our aid just to script the depots. One of the first things we had to think about was people coming in on depot into our reduction program. And that's when we hooked up with Nick to look at how were we going to manage reduction off depot. And through that came the trial of looking at what the withdrawal symptoms were going to look like, and to give an evidence base to that and to allow us to feel confident in doing that. So we were, very lucky to have participated in that trial. And because of that, we've continued to do reduction using depot. And because we've got the luxury of our own prescriber, we now do low dose transfers from methadone onto the depot. So around the 30 milligram, like Nick said, we can actually put them straight over to the depot. So that's helped manage those withdrawal symptoms off methadone, and hopefully we'll do a little internal trial on that and have some findings, but it really does seem to be a much easier coming off that smaller dose of methadone. And having worked in public clinics previous to whose, I know how hard it is for people just to come off those small doses, and some people might have the intent to come off their treatment, but linger on very small doses in the community, because they probably may not have the support that they have coming into the residential service. Like Nick said, you need, that support, and very important to, work around, the possibility of relapse and have all those harm reduction measures in place. So, we place a big emphasis on, overdose prevention, take home naloxone. I think it's very important for non-government services to, take up, especially take home naloxone if you're working with people on opioid treatment. So what happened too around the time Depot came in was COVID happened, and there was a huge increase, as Nick can attest to, in the public sector of putting people on Depot because it meant they didn't have to come in so often to pick up their doses. So then obviously we had an influx. So we really had to be ready for Depot. And obviously the nurses were trained up in, giving the Depot. At that time it was Buvidal that got passed first. And that's what definitely had the biggest uptake. And we didn't want any barriers to either our stabilisation program or our reduction program in being able to offer that to people, no matter what their dosage was. I know I just had a snapshot look at people in our program in July, and it's similar to what Nick said. We're seeing an increase in people on Depot, especially in our stabilisation program. The other thing as well is people coming out of custody on Depot. And in July, I think we had, out of the 50 people, we had 29 on Depot. We had a handful on still on sublingual, and the methadone's going down. There was probably 20 odd, but definitely the increase in Depot we're seeing. It's interesting actually. Some of the people coming out of custody on Depot, all of a sudden they say, "I've got I get side effects from Depot. Can I please go back onto the film?" But I realised probably not a good thing to do, because if, especially if someone's in drug court or something, they may return to custody. They're going to have to go back onto the Depot anyway. But, you have to also think of diversion, because the film has a great value in custody. And so these days we say, come in on a particular medication and, pretty well stay on that. We do have the ability to monitor doses so that, we can either increase medication or decrease if needed. We find that people with Buvidal tend to want it at the 3-week mark in residential, probably because they know it is easier for them to get that, but most do prefer the 3-week mark. We've had a few people on Sublocade, not many though, not many, and we would take them more into our stabilisation program because we don't know what the withdrawal off the Sublocade is, so we swap people over to Buvidal if they did want to come off, because we haven't quite, Sublocade has a longer half-life, so we don't quite know what the withdrawal would be like. But usually people are quite happy to swap over if their goal is to come off. And obviously we try and accommodate people's goals when they come into our services. I mean, buprenorphine, for those who haven't worked with bup, it's less has a less sedative effect than methadone. Some of our people still prefer that sedative effect of methadone. That's why we still see a cohort on methadone. But bup is much less, you wouldn't know if someone's on treatment, potentially, if they're on buprenorphine. I'm just trying to think of any. I mean, it's obviously a game changer for our opioid treatment population. It gives them much more freedom in terms of the monthly injection. And, if we're happy to put people over. We can't do high dose transfers from methadone to Buvidal, but if someone did want to do that at some point, we could look at them going into possibly an inpatient setting. We just haven't got there yet, but it's not to say we won't get there at some point. But I know that is happening in public health, the higher dose transfers and microdosing. That's a whole other area, I guess. It's probably a good overview of how we manage things. But like I said, we're very lucky to have programs for people, and that we manage so many people on opioid treatment. We probably have more but that's around our funded numbers. And I love working with people on opioid treatment. It's my favourite. They're my favourites. And I guess that's it. And happy to answer any questions later on just around our model. But, I think I've covered pretty much what we do at Who's.
Thanks, Carol. That was very
No worries.
comprehensive. So we'll move on to Fran from the Buttery.
Thanks, Michelle, and thanks everyone for having me here today. The Buttery, for those of you who don't know, is an organisation that's located up in the mid-north and north coast in New South Wales, and we provide mental health and drug and alcohol residential and community outreach services. So we started seeing people on Buvidal in about 2021, around about there. And we support people who onto Buvidal. We support people with Buvidal in 3 ways. We support people to commence on Buvidal, or long-acting injectable, should I say. We actually haven't seen anyone on Sublocade up here, so forgive me for that. So, for example, we might enrol people into our community outreach programs, provide them with counselling, case management and advocacy, and then we'll partner with the local health district GPs for assessment and community or inpatient commencement on medication and treatment. We support people who are already on long-acting injectables, and so we might do that through enrolment in our community outreach programs. We might provide drop-in support, long-term counselling and case management, and our focus here is really on psychosocial capacity building, where we support people to remain engaged in the treatment of their choice, and at times that happens to be long-acting injectables. And the third way is we support people who choose to reduce off long-acting injectables, and we do that through our 3-month residential rehab, similar to what Carolyn was talking about before, and we do that underneath the supervision of our GP. There were a couple of challenges that we had that might be specific to our organisation when starting to implement long-acting injectables into our different programs. The main thing that we had with our residential rehab, where we have a 3-month program where you can come in and we will support reduction of opiate replacement therapy, was that we actually don't have any registered nurses working here. We didn't have any facility to actually provide any injections at all. So we do have RNs working in our organisation. I am one as well, but not actually providing that kind of care with our clients. So we were really worried that we would either not be able to bring people in on any dose other than 64, which would be really unfortunate. And we were a bit concerned that people might be coming off it and then wanting to go back on it, which is their choice, and not being able to provide that as well. So, and, you know, people leaving in the middle of the night or something with, you know, some withdrawals, which would be a really terrible outcome. So they were the kind of things that we were really facing at the time. And so what we did was we didn't want to not bring anyone in. So what we did was we addressed the deficits in our organisation by partnering with the LHD, so the local health district, and we would transport people across to the local health district. It's about an hour and a half round trip to provide the administration of those injections so that we could bring in people on any dose and actually support them to titrate down. And we also simultaneously, we built capacity with our general practitioner and freed up some time with her so that she would be able to actually provide those in-house. And so I'm really, you know, happy that that has worked out for us. So we've been able to actually now bring in anybody on any amount of long-acting injectables who might be interested in moving to abstinence, and we're able to provide the medications in-house as well. Anecdotally, we do have quite a small program, but we have experienced people reporting, as Nick and Carolyn was saying, very, very low to no symptoms. So symptoms, for example, insomnia and restless legs, which we would be seeing on other types of medications, we're not seeing at all for people coming down on this. It's been very, very promising in that area. One of the other challenges that we had might be mainly because we're regional and remote, and we manage some programs that are really, really out, say at Tabulum, for example, casino places like that. And so we have quite a high level of geographic disadvantage and a lot of high priority populations in our cohorts in community outreach as well. So that can really be a barrier for people seeking any kind of treatment. So one of the things that we do there was we really harness our partnerships. And so that includes, you know, with the LHD, GPs and pharmacies, of course, but also priority population organisations, you know, youth organisations, First Nations organisations as well, just to get that engagement and support people in the way that's appropriate for them. Some of the things that have been really helpful for us is just to remember, we just like to keep it back to the basics and remember that to empower our staff with as much information as we can give them. So guidelines such as these are really, really valuable. And remember, there's a brief as well for anyone who gets overwhelmed with lots of information. So there's a brief guide too. Remember just to advocate for your clients. This is one of many, many treatments, and our job is to empower them to make informed choices. Linkages, partner with other organisations as much as absolutely possible. The better that you have stronger partnerships, the better continuity care, transfer of care, disengagement, it reduces and the clients get better outcomes. Follow the clinical care standards for treatment, of course. Consider safety such as take-home naloxone, and don't forget family support. Supporting those who support people engaged in our care will only strengthen the community as a whole. And with the pharmacy, GP and LHD, I just can't emphasise enough of the relationship. So we're working with some pharmacies who can actually administer in the Mid-North Coast, which is really fantastic for us. And we do things like co-locate with the local health district, create partnership committees with them, and NGO, AOD specialty partnerships with the LHD, and yeah, just participate in as many things locally as you can and strengthen those relationships. That's about all I have to say.
Thanks, Fran. That was great. And yes, Nick.
Yeah, can I just add, because Francis picked up on a couple of points, which I think maybe not everyone understands, that there's been a big change in the way that clients now pay for opioid medication treatment. Once upon a time, they had to pay on average around $40 a week to a community pharmacy. They were going to private clinics, are paying about $90 roughly a week for their medication, being on methadone or Suboxone. Started about 12 months ago, but actually only finally took final effect from the 1st of July of this year, is the new changes in the PBS. So now patients on methadone or buprenorphine, that medication is now covered on the PBS. So if patients have a healthcare card, They only pay the $6.80 or $7 per script. In most patients, a script will last between 1 and 3 months. So most patients are paying about $7 every 1 to 3 months. This is a huge change from the $40 a week that used to happen before. With the depot medications, likewise, it is the $7 per script. And again, that will usually last between 1 and 3 months. Most scripts will be that. That's if you're a healthcare card. If you're not on a healthcare card, then it is like any other medications, around $30 per script. But it is still so much cheaper than what it used to be. So there's been a major change. It's also made that issue that if you're an NGO and you're sending your patients to the local pharmacy, the pharmacist still wanted to get paid. Who's paying my $40? And so the patient would often be paying the NGO for living in the NGO. And then so their social security was going to the NGO, but then they still had to find the money for going to a pharmacy for their methadone dosing. So that was always really problematic, whereas now that's kind of not an issue. The other big change that's happened, though, is that now, as of the 1st of July, doctors and nurses can no longer administer depot injections that have not been dispensed by a pharmacist. A pharmacist now must dispense the medications. So it's not like we could do up until July of this year, where a nurse or a doctor could just rock up with a bag of Buverdals and, according to what the patient needed, just start jabbing away. We can't do that anymore. The medication must be dispensed at a pharmacy, which means named patient with a named, with a specific script. So it has to be written for, Joe Bloggs, and Joe Bloggs is getting 64 milligrams of Buverdal. So that needs to be, so that does make it a little, it means if you're in an NGO, it's probably easier nowadays just to get them to a pharmacist that administers, rather than trying to negotiate this through a GP or an LHD.
Thanks, Nick.
Yeah, I can add just to that, because I mean, we have a license to dispense, but we can order, historically up till June 30th, we were ordering whatever, not a problem. Because we didn't have to pay up front. Well, it was no cost to us. The government paid as of July 1st. You have to pay up front for the medications now. Although, you've got to pay. Interestingly, I tried to order some Suboxone, Suboxone, and they wanted the money up front. They wouldn't give it. And then it's really hard. They won't even send you an invoice to pay. Anyway, there's all these things you have to navigate. But we were lucky we had a pharmacy who does all our Webster packing for our residential clients, and they were also dispensing opioid treatment. So they agreed that we can send the scripts to them for the depot, because the depots are about $350 each for 1 month. So we obviously couldn't put that into our scope to ensure clients didn't have to pay for their medication. So now we only have to pay for the $7.20 script at the pharmacy. They dispense it, they deliver it to us, we administer it. So you have to negotiate those things, with depot and the changes. But it's amazing that, for our people, that they don't have to pay those exorbitant dispensing fees anymore.
Yeah, that's really good to know. That actually leads into one of the questions we had from the audience. So there's a question: if we're a small organisation, what do we need to consider or to organise if changing our criteria to take people on long-acting injectable?
I mean, my advice is get into a relationship with your local pharmacy. I think that's going to be the most important thing, rather than this idea that the LHD is going to, take over. you have to appreciate, folks, the LHDs are absolutely smashed when it comes to numbers. They are most LHDs are running at 20 to 40% higher treatment numbers than what they were funded for. And there was no increase for opiate treatment out of the ICE inquiry. So there was no increase for OTP clinics. So, don't think that your LHD OTP has got the capacity to do this. They may do, and I'm not saying don't talk to them about it, but you can't expect it, especially since it's actually, the whole thing now is really more about finding a pharmacy that can administer, that can actually inject the patient. That's if you don't employ nurses. If you employ nurses, then you can do as Caroline said, the pharmacist can then dispense the meds and send them over to the NGO, and then your nurse just jabs the patient. That's easy. So if you're employing nurses, work with your local pharmacy and they will dispense the meds to you. And if you're not employing nurses, get a pharmacy that will administer. And every pharmacy is allowed to. There is no special training. There is no special requirements.
While we've got you, Nick, there's a question around just asking if you could talk a little bit more about the side effects.
Yeah. Look, thanks. Look, buprenorphine is buprenorphine. Most of the side effects that you're going to get with the depots are the same side effects you're going to get with just using Suboxone. And what are they? They tend to be side effects to all opiates tend to be most common when someone starts the medication. Even though people have been using heroin or other opiates, people's reaction to different opiates can vary. So you might get a side effect to one opiate that you don't get with another opiate. That's not uncommon with opiates. So some patients describe, for example, that when they first start buprenorphine, they get quite nauseous. Other people say they get constipated. Some people, the other common one is some people say that they get sedated early in treatment. And for a small group of people, they get the opposite effect where they feel quite wired, like actually a little bit hyper in the first few days of buprenorphine treatment. So you can get all of that. Most of that tends to settle down with time. It's usually the first week or so where patients can have some of those side effects. And that's the same whether or not you're on a depot or whether or not you're on sublingual. The other types of side effects that you get with the depot relate to the local dose, to the injection. And so the most common ones there is about 10% of patients describe pain. It's the pain of an injection, and a similar proportion describe a lump after, where the injection site is. This tends to be more common with Sublocade than with Buvidal, but can happen with both. They tend to be the most common side effects. Occasionally, you can get more severe problems, and that usually arises through poor injecting technique. So if the nurse or doctor or pharmacist doesn't inject deep enough, and they do it intradermally, so, they're cautious, I don't want to go too deep, and they sort of inject too shallow, then you can get kind of almost like a blistering of the skin. So it does require a little bit of training to do the injections properly. And the bottom line is you just stick the needle all the way in. That's simple, basically, all the way in. And, that's the way to avoid that problem of injecting too shallow.
Thank you. And another question we had was around pregnancy. So can you talk a bit about the guidelines in pregnancy now? I know there's the new substance use in pregnancy guidelines that have come out, which includes a bit about long-acting injectable bupe. But
yeah, so when we first got the buprenorphine 5 years ago, the pregnancy label was still kind of like a warning label. We didn't have much data around it. That now has pretty much been lifted. So now, you know, there's no real difference whether or not you're on a Suboxone or a Depo or a methadone for that matter. Most guidelines around the world now generally would promote buprenorphine as being better in pregnancy than methadone. And that really has to do with the severity of the neonatal abstinence syndrome. So it's less severe for babies when they have to withdraw for a buprenorphine compared to a methadone during pregnancy. So generally we say bupe's probably better than methadone, and between sublingual and Depo, look, whatever the patient's already on, just generally just keep it going. Sometimes, you know, we have some women that are really scrappy, you know, messy in turning up for dosing during pregnancy, you know, either because it's travel or they get morning sickness or whatever. And with those women, that's when we might think a Depo is going to be better, because it's not as though the woman's going in and out of withdrawal during pregnancy. Because if the mum's going through withdrawal, that means fetus is going through withdrawal as well.
Thanks, Nick. Were there any more questions? So if there weren't, I'll just move along. I'll go back to share these resources that we've put in the chat. So we have the long-acting injectable buprenorphine for opioid dependence treatment guideline, which was just recently re-released, which Nick was the lead author on. The clinical care standards for alcohol and other drug treatment, which is a New South Wales Health guidelines on standards across the NGO sector as well as the health sector, which Francis mentioned as well. The clinical guidelines for opioid dependence, which came out in 2018, and then recently released clinical guidance for the management of substance use in pregnancy and postnatal period. So we've put those links in the chat.
Can I suggest to, because I know a lot of the guidelines that New South Wales helps develop can often be a little bit scary, because they're a 100-page document, and the thing though that we've done with the Depo guidelines, we've got the long version, which is the scary 100-page document, but we also have released a brief guide as well, which is only like about 10 pages. And I would certainly encourage, go have a look at the brief guide. That gives you the overview you need. And then the full guidelines is really, minutiae of, like the details. But if you just want a quick overview of what, of all the information I sort of need to know to understand Depo treatment, and the brief guidelines is a simple read.
Yeah, thanks, Nick. And the other one that is available is the newer opioid treatment guidelines, which are downloadable as well. They're consumer guidelines, which are good resources as well for your clients. So we've come to the end of the webinar. So any other questions that come through, we will pass on to the presenters and then provide answers in the coming days. So I'd like to thank Francis, Nick and Carol for participating in this webinar today and providing all this information. And thank everybody online for participating as well. A short evaluation survey will be emailed out, and we'd appreciate any feedback that you have. And also visit the NADA website, so nada.org.au, for any further resources or information. We also have regular email updates that go out. So thank you, everybody, and we'll see you next time.
Thank you.
Thank you.
Thank you so much.